Recording? There we go. Okay. So yesterday, remember we did joints and soft tissue. Today, we're going to move on to actual bone disorders. So our objectives for today, what we're going to be doing. Is everything okay? Okay. So we're going to do a little bit of A&P review, and then we'll go right into our different diseases, bone fractures, osteonecrosis, osteomyelitis, and then finally end with osteoporosis. So function of anatomy again, support, protection, and locomotion, helps us move, red blood cells, storage, and regulation, remember, of calcium and phosphate. That's really main job of that is just storing all that stuff. Whenever we need it, we just leach it and pull it back. The epiphyseal plate is the growth plate. So as that seals, you're not going to grow anymore, which is why when we have fractures in that growth plate, we're worried about growth in that bone for that patient. And then the periosteum is the outer layer. Here's the anatomy of a long bone again. Here is our cartilage cap, so that's where all the hyaline cartilage is for the movement between the next bone for the joint. Here is that growth plate. Then we have cancellous bone, and we have cortical bone. The cortical bone is obviously in the middle with the medullary cavity. This is where hematopoiesis takes place in the medullary part of the bone. The diaphysis is just the long shaft of the bone. It's called the diaphysis, made of cortical bone, and it's very, very, very strong bone in the middle. Metaphyses at the end. And then the epiphysis is the growth plate. Within the bones, we have different types of bone depending on the structure and the function of that bone and where it is. We have cortical or compact bone, and that's mainly in the shafts of the long bones. It's going to be that cortical bone. Very, very strong mechanical and protective forces. It has these things called Haversian canals. These will become very important when we talk about like osteonecrosis and osteomyelitis. These Haversian canals play a role there. The second part of the bone is this trabecular or cancellous bone, and it's called spongy bone because it looks like a sponge under the microscope. This is at the ends of the long bones, in flat bones, and in the vertebral bodies of your spine is where you're going to find this soft bone. It's composed of a meshwork of trabeculae. So a mesh, when I show you a picture, it looks like, oh, it looks like a sponge, like a mesh. Metabolic activities occur here and serves to reduce skeletal weight without compromising strength. Okay, if our bones were solid the whole way through, we'd weigh a lot more. That's why birds can fly, because their bones are lighter. The weight doesn't matter, and they can fly. That's why we can't. Within the bone, we have cells there as well. We have three different types. We have osteoblasts, and they build bone. Okay. We have osteocytes, and that is the mature bone. So if you ever see an osteocyte, that means that bone has been matured, and it's been there for a while. And the last one are these osteoclasts. And they're the ones that break down the bone, and their job, again, is to put calcium back into the bloodstream. When calcium levels drop, they get too low, body doesn't like it, we need calcium. Well, luckily, we have 206 bones of calcium ready to be leached. So, bone remodeling phases. PTH is going to be present here. Okay. What is the job of PTH, parathyroid hormone? How? Breaking down the bone. So the purpose of PTH is when you have low calcium in the blood, hypocalcemia, PTH comes out and gets the bone to break down so that we can reabsorb all that calcium and get it back into the bloodstream. However, if this process keeps going, and we have chronically low calcium, What is a condition that we learned about where they're going to have low calcium? Kidney disease, right? Kidney disease. They're not going to make vitamin D. They're not going to activate the vitamin D. Therefore, calcium levels are going to be low. So PTH is going to come out, right? Because it's got to. But because this person has an underlying renal disease, is that calcium ever really going to come up naturally by itself? No. So do you think PTH will always be having to be released because we're chronically low calcium? But the problem is, what's PTH going to do to the bone? Break it down. And if you have constant PTH going on for chronically, you don't want to have all your bones become so brittle because of the PTH. So what happens with PTH? After a certain amount of time, 3 months down the road, in a chronic fashion, PTH will revert to actually build bone back. Okay, so in the acute phase of PTH, it's going to break down the bone, putting calcium back in. But in a chronic secretion of PTH, we can't have that degradation keep going unchecked. Our bones will get brittle and they're going to break. So in a chronic release of PTH, it is anabolic. It's going to build up the bones so that we don't severely deform our bones and cause problems. So if we break it up into sections, we have our pre-osteoclasts. They come to the area and they cause bone resorption to occur. And then over time in the chronic phase, we have pre-osteoblasts start to come into the zone and rebuild back the bone. So this is a chronically released PTH. But in the acute phase, when we need that calcium up, PTH will do its job. This, again, is referring to, we talked about yesterday. Let's do it this way. Why is this pen not working now? Oh well. Anyway, compressive forces. As we're walking, as we step and weight bearing, the forces are going straight down via gravity, going through the legs into the feet. What this is saying is when we have unequal forces, if you see the thickness of these arrows, it's very thick on the right side. Let me see. Okay? Very thick right here, because this is the majority of where the weight bearing is occurring. On that side, it's very, very minimal. So because the lateral side is weak as far as not getting a lot of compressive forces, but the medial side is getting a lot, what will happen is the bone's going to remodel. We're going to remove bone from the side that's not under the compressive forces, and we're going to add new bone to the side where there are compressive forces. This is bone remodeling. This is why weight training is so important. We talked about it yesterday. This is that Wolff's Law where the bone is going to remodel based on the forces applied to it. And that's how our bones change shape, depending on what you're doing. Okay. Obviously, regulating hormones, PTH, we already discussed a little bit. Extracellular calcium, the osteocytes have a role here as well. There we go. To release calcium that's stored in the bone and to rapid response. But again, if PTH stimulus continues, osteoclasts are signaled to resorb bone breakdown and then more bone breakdown. But in that chronic phase, so let's say, why does the pen not work? Anyway, 3 to 4 weeks of constant PTH secretion, eventually the bone will start building its back up.
In the chronic phase, are you as worried about calcium then? PTH is still helping actually?
So what are we going to do? If we catch someone in this phase, we're going to give them calcium anyway, or vitamin D. We'll just give it to them.
Okay.
Rather than let the PTH do all the work, we'll just give them calcium.
Gotcha.
Again, PTH, what's the effects in the kidneys? Remember, it's going to increase phosphate diuresis. Why is that important? Why is the kidney going to get rid of phosphate? It doesn't do anything. We don't need it in the blood system, but remember, when we break down the bone, it's not just calcium, phosphate comes out too. But we don't want the phosphate, we need the calcium. So PTH will tell the kidneys, hey, get rid of the phosphate, we don't need it, but keep the calcium. Stimulate calcium absorption, get the active vitamin D form flowing, goes to the intestines and it tells the intestines to increase absorption of calcium. And in our summary slide, looking at PTH, vitamin D, and their different effects. But we've already gone over all that in physio. Vitamin D comes from the food or from UV rays. That's why getting out in the sun is so important. We don't go out in the sun enough anymore. Stored in the liver and fat. Stored when vitamin D levels are high. So when you eat a lot of vitamin D, you store it. Whatever's excess, you pee out. That's why I tell you supplements, for the most part, make you have expensive pee. Because for the most part, you're going to be stacked up on all those minerals and stuff anyway. And all the excess, you're just going to pee out. If you have a normal diet, you've got everything you need. If you're immunocompromised, severely elderly, you're not eating, yes, you need supplementation. But if you have a normal diet, you're fine. Regulating vitamin D, the primary target is the intestines. Again, it's going to stimulate more absorption of calcium. So vitamin D just tells the intestines to absorb more calcium. In the bone, vitamin D augments PTH-stimulated resorption of the bone, may have some role in mineralization, and in the kidney, obviously, it'll have a feedback on itself. When vitamin D levels are appropriate range, we don't need to make any more, and we're okay. Calcitonin, we don't talk about very much. It's a very, very, very weak effect in our bodies. The main effect is that when we have too much calcium, we have to get rid of the calcium. Calcitonin is the hormone that's supposed to put the calcium back into the bone, but it's very weak. We don't really use it that much. The only time we really look at calcitonin is if we think they have an underlying parathyroid hormone problem. That's when we start looking at what are your levels of calcitonin in the blood, and we start putting the pieces together. Remember, when you guys do diagnostic testing, whether it's labs, imaging, those are there to confirm or rule out your diagnoses. You're not going to be like, oh, I don't know how to do a really good H&P, so I'm just going to order everything under the sun. Let's see what you find. That's horrible medicine, very costly. You subject your patients to a lot of exposure of things they don't need, like CT scans. They don't need those all the time. So again, history and physical, the imaging labs are to reinforce your decisions. Big thing here is remember this. Serum has the priority over the bone. We care about the blood calcium levels, not the bone calcium levels. We care about calcium in the blood. Bone just stores it for us. Phosphate, 85% in the bone, so it comes out as well. But remember, PTH will cause it to come out, but PTH will also have it to be excreted in the urine so we don't get hyperphosphatemia. Other hormones involved with bones, insulin is there for skeletal growth. Thyroid hormone obviously is very important. Growth hormone, your sex steroids, and glucocorticoids, okay? People who have rheumatoid arthritis, we talked about that yesterday. The treatment, the long-term treatment for rheumatoid arthritis is giving them steroids. Okay, giving them cortisol, I take that, or some form of that every day. The problem is, as you take too many cortisol, too much steroids, it actually can weaken the bones. So one of the side effects of chronic steroid use is osteoporosis. So if you have a patient who has rheumatoid arthritis, what would you think would be very important to check on that patient every year? Bone density, very good. And that's why you start incorporating those things into your patient education for your patients. Estrogen and bones. Estrogen is key hormone for maintaining bone mass. That is why osteoporosis in women happens after menopause very rapidly, because there's no more estrogen there, and that's when they get it. The same thing with women in heart disease. It happens after menopause when estrogen drops. Remember, estrogen is also cardioprotective. And when they hit menopause, no more estrogen or just drops to subtherapeutic levels, bone mass is going to drop as well. Obviously, deficiency is a major cause of age-related bone mass. So again, estrogen is very important for that. Okay, there's our physio review. Let's move on to some diseases. So metabolic disease of the bones, there's two of them, Paget's disease and gout. So Paget's disease is also known as osteitis deformans. So either way, make sure you know them both. It's a chronic condition with disordered bone remodeling. Osteitis deformans, it's deformed. Your bones are deformed. That's what Paget's disease is. It's excessive bone resorption with disorganized and excessive bone formation. So as the bones are getting degraded, we're trying to repair the bones, but it's not being repaired very, very well. They may be solitary lesions, or they can occur at multiple sites. Usually, this Paget's disease is localized to bones of the skeleton, of the axial skeleton, head, and trunk. I think I have it a little bit later, but in some patients with osteitis deformans, with Paget's disease, the skull can get so heavy from being remodeled that it will actually can crush your C1 because of the weight of the skull, compressed C1. Second most common bone disorder in the US, what's number one? Osteoporosis, very good. Men and women, both over age of 50, high incidence in people of English descent, and etiology unknown, but it may be viral. So whenever it says viral in origin, remember that virus is what is the insult that starts that cascade that leads into something else. We've heard of this before with viruses doing that. They hit you, and like 3 weeks later, you have other things going on. In the renal system, acute glomerulonephritis. Remember that group A strep they had weeks prior, and then they present with that. Preceding infections. So there are 3 different phases that are going on with Paget's disease. They don't have to necessarily go in order. All 3 phases can be present at one time, but there are 3 different phases. The first one is called a hot phase. This is osteoclastic stage. So osteoclasts, so what's going to happen to the bone? Breakdown. So we're breaking down the bone. So bones are breaking down. Then we have a mixed stage of osteoblast and osteoclast activity. What's going to happen? The cortex thickens, causing bones to become larger than normal and distorted. So that is the mixed stage. Then finally we have the cold stage or the burnt out stage. Very, very little cellular activity, and your radiographs will show thickened and disordered bones. And I have plenty of pictures to show you in a second. And again, they may be in all stages at once. So this is what trabecular bone looks like. Okay? A lot of canals, looks like a sponge. If you did a microscope of a sponge, that's what it looks like. Now look at the bottom picture. That is what happens with Paget's disease. Disordered bone remodeling. Okay? Also resembles a mosaic pattern. Okay? Mosaics. You do the thing where you break the tile and you make a new image or whatever. So mosaics. So again, normal is on top and the Paget's disease bone is on the bottom. Here's the lamellar bone. Again, look at that normal, look how nice and clean everything is, and look at that, the bottom one. So that's Paget's disease, disordered remodeling of the bone. So what kind of signs and symptoms are patients going to present with? Pain is the biggest one. A lot of pain in the area that the bones are undergoing all this remodeling. That's where they're going to have their pain. And again, usually the axial skeleton, anything in that center part of the spine. Skull, again, frequently involved, and again, become very heavy and can collapse over C1. Hearing loss if they have any involvement with the ossicles. Fractures and arthritis, bones will snap transversely right across. Sometimes people with Paget's disease also present with high output cardiac failure, which is very rare. It shunts blood to the bones due to increased demand. Okay, all this remodeling, remember, needs blood supply to do all that. You have to have blood to the area. So because with this Paget's disease, they have this mixed stage where they're undergoing that osteoblast, osteoclast activity all at once, that requires a lot of blood. So blood will be shunted to the bones because of the demand, less blood flow to the kidney, and hopefully by now, we all know what happens when low blood flow goes to the kidney. I've repeated it like 500 times. I'm going to stop. I'm going to repeat it again. Diagnosis is often incidental. You're not going to see Paget's from the outside of a person. They're not going to present. They may have some conditions, and I'll show you what someone's lower leg may look like, but usually you won't see it. So this is what it can do to your tib-fib. Look how curved that leg is. Obviously, that's a very, very severe form of Paget's disease, but you can see here mosaic pattern inside very, very thick deposited bone, high density, from all that calcium being dumped into the bone for the repair. And that's Paget's disease. Any questions about Paget's disease? Yes?
So mobility-wise, what would you suggest for these patients? Because their bones are so frail, are they able to walk?
I mean, they are, but they have to be careful for fractures. So depending on if like that being weight bearing, she has to be very careful walking. Probably canes, walkers, to get the weight off of that foot so you don't break it. Okay.
Doesn't that also promote like loss of bone density, or is it just choosing one over the other?
Choose one or the other. Like that's what medicine mostly is going to be about. That's why you always weigh the risks and the benefits. What's the risk for doing this? What's the benefit? The benefit outweighs the risk, then we'll do it. And if it doesn't, then we wait. Like I gave you the example before with the rheumatoid arthritis, taking cortisol or hydrocortisone all the time, and then they get osteoporosis and whatnot. What's the benefit if they stop that medication, then the rheumatoid arthritis gets inflamed and goes crazy. But if they take the cortisol, then they get osteoporosis. So I'll just give them Fosamax or something to help, a bisphosphonate to help with their calcium in their bones. It's always a give and take. What's going to kill the patient if I don't treat it, or what can be waited for later? So as we go through all that. So next up is gout. Okay, it's a metabolic disorder due to elevated serum uric acid concentration called hyperuricemia. Incidence has increased with the rise in obesity and hypertension. Relatively common. 3.9% of the population will have an incident of gout at some point in their life. Typical range, 40 to 60. Monosodium urate crystals deposit in and around the joints and tendons, and they supersaturate. So we talked about calcium stones, how when too much concentration, they come out of solution and they precipitate out. Same thing here with uric acid. Uric acid levels rise too much, they get supersaturated and they crystallize out of solution, and now we got uric acid crystals. And I'll show you pictures of that. They're very, very sharp little needles. And imagine these sharp little needles inside the joint. And every time you move it, those needles just dig into that joint, causing immense amounts of pain. That's essentially what gout is. It can be recurrent, acute on chronic. What's going on with your patient? So if it's a chronic condition of gout, you got to put them on medication for that. Diet is the biggest change when it comes to gout. I'll show you some list of foods that can cause gout. There are classifications of gout, primary or secondary. Primary is just due to the hyperuricemia without any disease. That's the most common one. I'm sorry, 1/3 of the cases are primary. Secondary is there's another underlying disease that's causing this uric acid levels to go up. So here are some examples: leukemia, treatment, lymphoma, status post chemo. Anything that involves with high DNA turnover can do that as well. So secondary or primary. So uric acid comes from purine catabolism. So purines, they're in foods, and as our body metabolizes the purines, we make uric acid. So what are the different ways we can have a buildup of uric acid in the body? Number one, we just make too much purines. Okay, overproduction. Another one, decreased uric acid secretion. We're not getting rid of it in the kidneys. If we're not getting rid of this, it's going to build up in the blood, getting stronger and stronger. 90% of idiopathic cases, again, impaired renal uric acid secretion, not high dietary intake. The problem with these people is the kidneys can't get rid of the uric acid, so it builds up. Not because we're eating too much purine. Diuretic administration. Okay, water losses result in higher concentrations of uric acid in the blood. So giving diuretics, you're going to lose that out. It can precipitate out, causing the crystals to form. And the last one is increased catabolism or breakdown of the nucleic acids for that greater cell turnover that we talked about with the 2/3 of the cases. This one. High DNA turnover is what this one is talking about. So these are some foods that are very high in purine. Okay, a lot of your the fish and organ meats have high purine in them. Okay. So again, gout, needle-shaped monosodium urate crystals is what the full term is called for those uric acid crystals. They can get deposited in avascular tissues like cartilage, relatively avascular like tendons and ligaments, cool peripheral joints like the toe. So you'll see the big toe is usually a big site for gout. And when the toe is involved, the big toe, it's called podagra. It's just a simple, but it's still gout. It just means that it's gout of the great toe, podagra. It can go in the ears. I'll show you some pictures of the ear involvement. In long-standing severe gout, then you start getting into some other tissues and causing some problems. So deposition is determined by temperature and blood flow. Okay, that's why it's very common in our distal joints. The cooler joints, your fingers and toes are very far away from your core. They're going to feel cooler than your core is. So therefore, that's where the uric acid wants to go. And that's what it looks like. It's crystals. Okay. Very, very sharp little needles that will cause pain. Think about having all these needles in your joint and you're trying to move it. They're going to cause pain every time you move. So severe pain. Okay, they call it exquisitely tender. So when you see the word exquisite tenderness, it means it's very, very painful in a very specific part of the body. Joint is red, warm, very tender. Going to activate your kinin system so you get local vasodilation, pain, and swelling, and that complement pathway gets activated as well. Phagocytosis of the crystals by macrophages causes more pro-inflammatory cytokines. You get neutrophils coming in. Then the inflammatory response downregulates spontaneously and completely over several days without therapy. So gout can resolve on its own. It's when you have the recurrent gouts that you have to be careful, and there's medicines we can give to help with recurrent gout. So this is podagra, the erythema and redness in that big toe. Acute attacks start without warning. And again, usually acute monoarticular pain. Start keeping in mind, as you start learning about different diseases, what things present bilaterally and what things will always present unilaterally. Gout, unilaterally. Rheumatoid arthritis, bilateral, unilateral? Bilateral. Osteoarthritis. It can be unilateral, but it can be bilateral as well. Infected joint. Unilateral. DVT. CHF swelling. Bilateral. See, start thinking what thing will be bilateral, which ones are unilateral. And when you start seeing them, only one leg, okay, well, it can't be CHF because both legs will be swollen. That's when we start thinking about different things. So again, MTP of that big toe, podagra, may be precipitated by a large meal, drinking alcohol, trauma, surgery, or stress. So pain progressively more severe and very excruciating to the point where even the sheet, when they sleep at night, if the sheet or the blanket brushes that toe, immense pain. Very, very, very painful stuff. They will look like an acute infection. The swelling, the warmth, here's that exquisite tenderness I'm telling you about. Where if you saw this coming in, you would think, oh, there's an infection going on. But it's not, it's gout. Fever is common. Again, you think they're having an infection, but it's not. It's an inflammatory process due to these crystals getting into the joints. And there's different stages. Again, but the main key is uncontrolled hyperuricemia. As with, again, repeating myself, a lot of the cases we talk about is uncontrolled. You're not treating these things, left to their own devices, where are they going to end up? And your job is to not let them end up in that state. Okay, so clinical manifestations, podagra, one site of the arthritis, can waken them up at night. Flares do occur. And you can develop what's called gouty arthritis if they have birefringent urate crystals. So birefringent urate crystals. That's one of those fun Pants Prep Pearls things because birefringent crystals is uric acid. Tophi form. Tophi are subcutaneous nodules, but they're made up of uric acid. And I'll show you where those show up. Like tendinous structures, you can see them on the ear. I have some pictures of that. You can also get some erosive arthritis with repeated attacks to the same joint. It has to be the same joint. If it's bouncing to different areas, it's not going to do that. But if you have repeated gout inflammations to the same joint every time, over time you can get some erosive arthritis just from the constant inflammatory processes that are going on in that area all the time. They may also get some renal tubular injury. Nephrolithiasis may develop. So renal tubular injury, what type of renal failure is that? Pre, intra, or post? Intra. Okay, we're dealing with the kidney tissue itself. It's intrarenal failure. And a nephrolithiasis is just your kidney stones. So here are some example of the tophi. Here's tophi deposits. These are all uric acid crystals. Yes, they are nodules. We learned about nodules in derm. They are nodules, but they're made up of uric acid. And here's what this tophi look like in the ear. They can get deposited there as well. But again, these are just uric acid crystals. And here's that birefringent uric acid crystal. Again, these little needles cause immense pain in the joints. Okay, let's take a break. Come back at 1:20 and we'll start bone fractures.